My name is David Keane, Research Physiotherapist for the AIM trial. Before the detailed explanation and demonstration of close contact casting by Bob Hanley, there are a few clinical points we wanted to highlight regarding close contact casts applied during the AIM trial. Close contact casts are applied in the operating theatre under general or regional anaesthesia by an orthopaedic surgeon. The rationale for anaesthesia is to enable a sufficient application of pressure to reduce the fracture if it is displaced, and also to mould the cast effectively. We advise that casts should be applied once major swelling has subsided, at a similar time to when open surgery would be considered. Ensure you can achieve a reduction of the fracture using an image intensifier before setting up for the cast. Then practice holding the position of the leg for the cast moulding prior to applying the cast. The specific moulding points and correspondingly sited pressure pads within the cast aim to prevent fracture displacement while also minimising the risk of skin damage. The location of the moulding points are specific to the patient's fracture pattern, so the points of application required to hold the fracture are the decision of the treating surgeon. After application of the cast, each hospital in the AIM trial followed their own VTE prophylaxis protocols. We advise clinic follow-up with an orthopaedic surgeon at 1, 2 and 3 weeks after application of the cast to monitor the patient's cast and fracture position. At these clinical follow-up appointments, monitoring radiographs are used to check maintenance of the fracture position achieved in theatre. Radiographs are also repeated if reapplication of a moulded cast is required. Professor Willett has highlighted that there is less focus on cast management for unstable ankle fractures in contemporary practice in the UK, so we emphasise the need to monitor these casts. We expect the cast to start loosening as swelling reduces and muscle wasting occurs. To maintain close contact, there should be no space, and therefore moulded cast reapplication in the early weeks should be normal practice and anticipated. Recasting needs to be conducted at the earliest signs of loosening. Surgeons in the AIM trial were advised that tailor tilt or shift resulting in significant joint incongruence would be considered unacceptable, but as a pragmatic trial, this was ultimately a local clinical decision. We advised that there should be no more than touch weight bearing in the initial 4 weeks after application of the close contact cast, and then to build up to full weight bearing by 6 to 8 weeks as healing allows. Finally, as a pragmatic trial, the progression of rehabilitation during the AIM study was at the treating surgeon's discretion. Bob Hanley now discusses the method and demonstrates the application of close contact casting.